Thank you so much, Pamela. There was so much in there, which I think will be unpacked with the series of panels. So you touched on all the aspects that we will be looking at. And I think one of the things that during the last few months that I've been working and talking and had the opportunity to speak to all the panelists, I think for me one of the most fundamental things that came out was we have to listen and we have to recognize the power of the community to actually guide us in the way forward. And I think that's a very, very powerful message that I received, and I think we're going to hear all about it as we move forward. I would like to invite our first panel to go up, and we have regrets from Professor Roberto Beneduce, who is a professor of psychological and medical anthropology from the University of Turin. He cannot be with us physically because he has COVID, but he very generously offered to continue to moderate the panel via Zoom. Thank you, Zoom. So can I invite you to come up, please? And yes, and we'll go into our first panel. The other thing I wanted to remind everybody that this is an interactive event. So if you have questions, I hope you've all signed up to the app. In the app, for every panel, you will see there's a little, it's very, very very easy to follow. There is a little place where you can ask your question. If you see a question that you particularly want answered and you haven't asked it yourself, you can like it, which will mean that that question will be put forward above the others. So you all have a chance to participate in the questioning, and please do use the app. Thank you.
Thank you very much, Atalanti. Sorry for my absence, sorry for my broken English. I am very glad, and what I just heard before was for me very important. I remember just the words by Atalanti, the magic of many, and the concept of intersectionality that Pamela Collins mentioned before with regards to mental health and mental disease. I think that we have to consider our responsibility and our power. And our power is first the power of not forgetting what it was said just a few minutes ago. We know how much poverty affects mental health. We know how much COVID was able to destroy our peace, our communities, but we cannot forget the color of death in many countries. Just 2 days ago, I was speaking with a young student from Peru who said that his mother and many friends died in Peru because they didn't have money to pay oxygen. We cannot forget this trivial dimension of health and death and healing. I try to make an effort to avoid the trivialization of the word social determinants of health, because it is just, or it risks to become just a euphemism. I remember to myself that social determinants mean poverty and violence. When we consider mental health of women, all these increases in a very dramatic way. And again, we know. My students in medical anthropology from Iran, a girl, was crying. Her dissertation thesis was about culture and depression in Iran. But after these 3 weeks, we spoke together and we were forced to remember ourselves that depression among women in Iran is not just an issue of culture or religion. So, how we can put our awareness about these dramatic issues and transform them in concrete actions. Second issues. I think that this is the right context for remember to ourselves another kind of responsibility, avoiding the temptation of a shortcut, medicalization, diagnosis, and so on. I remember the book Pharmacracy. I consider this book very useful in order to remember the heavy interest of big pharma in vehiculating false ideas about the way by which we can treat, even in low-income countries, suffering. And this is the right context to critically reflect about this. Third, and I stop my few words, I remember that concerning the words and the diagnosis, we have to be able to connect the bad past with the current suffering. Of course, migrants, people affected by racial violence speak about the past and the present. I refuse to say that migrants from Africa have persecutory ideas about the color of their skin and the glands of Italians, because I know that they are true, their experience is true. And in the same way, people, I'm considering girls and women in Mozambique, where I working since many years, when they are affected by what my colleagues call epidemic of trans, they are victims of current violence in the school, as well as past violence in the family and in the places. How can we put this information and reimagine psychiatry and reimagine mental health and reimagine the right to the healing, above all for women and for people that have not other way to access to this opportunity of healing. So I think that we have to take literally this moment as an important moment to reinvent our strategies. Thank you again for your patience, of course. First of all, for my English, I think that I can give a word to the panelists, starting by Julian Eaton, because I will follow the names on the list I received. So please, Julian Eaton, working in as a mental health director in CBM Global and Center for Mental Health. Please, you can speak.
Thank you. Thank you for the opportunity to come and speak to you all today, for this chance to really speak to quite a remarkable group of people, all of whom I've had the opportunity to speak to several people over lunch and over dinner last night. Sorry. Thank you. I hope that's okay. Now, I've had the opportunity to speak to quite a few people over the last couple of days, and there is some amazing work being done by different organizations who are part of Giving Women. And several people started their conversations with me by saying, it's great that we're doing mental health this year, that we're talking about mental health in the conference this year, but of course my own organizations' work isn't really very much to do with mental health. And of course it is. In almost every case. Someone's going to come up to me at lunchtime and persuade me that their own thing isn't to do with mental health. But in general, mental health is an issue that pervades all of our lives. And that is often in the areas that you've talked about, Roberto, areas that affect poverty. Many of you work in organizations that have an impact on reducing poverty, or violence, interpersonal violence, or people's access to work, or other essential rights that they have. So in many ways, all of your work is touching on this already. I want to just start in this huge area. We've heard so much from you, Pamela, already, and also from Roberto. It's difficult to know where to start. I just want to give a little sense of where my work has increasingly led me, and think maybe about a way that we can start to address some of the things that prevent people from accessing the rights that can help them to have a fulfilling life and strengthen and improve well-being. I work for an organization that's primarily concerned with people with disabilities, and have had the great privilege over the last 20 years or so of thinking about how what has been called mental health, in quite a kind of health-orientated way, relates to disability. And that has taught me so much, coming from a medical and psychiatric background, to having this opportunity to think in a much richer, more social way about the things that impact people's well-being. There is a risk when you finish medical training of being quite arrogant, as many of you will know, and of thinking you have answers. And I have spent all of that time since then realizing how few answers I have, and how many of the solutions to these problems lie in the communities where we work. We work across Africa and Asia and Latin America. And particularly, what I've learned has been the power and importance of people themselves having the opportunity to demonstrate their capacities and to engage with communities. And that particularly has come out around the work we've done in Stigma. Stigma is a word that's, on the one hand, everyone understands what stigma means, and it's also a word that can be incredibly complicated in its many different manifestations in different ways. But what we have found in good and increasingly strong research is that attitudes and myths and stereotypes are very persistent, difficult to break down until people meet people, until they meet individuals, and those individuals are able to form a relationship with them, and that's when stigma starts to break down. So we have people who have multiple vulnerabilities, multiple reasons why they're marginalized and excluded, which gives them the greater risks that you talked about, Pamela. But the emancipation from that, the power that comes out of those people being able to have the opportunity to have their voice heard. And I think the most powerful thing we've done over the last 20 years is to realize the importance of people coming together who have shared cause, common cause, whether that's around a health issue or around a social justice issue, and being able to find the solutions themselves and engage with communities to break down some of those stigmatizing issues that they have to deal with of exclusion. So I'm going to stop there because I've talked for quite a long time already, and hand over. Thank you.
Thank you very much, Julian. I think that now is the time of Inka Weissebecker, of a mental health technical officer of WHO. Sorry for not following the I'm following the list of names I received. Sorry. Prefer as you want, freely.
Okay, sure. Hello, everyone. My name is Inka Weissebecker, and I'm a technical officer at the World Health Organization in Geneva as part of the Mental Health and Substance Use Department. It's wonderful to see so many of you here, and also great to have people online as well. I just want to add a few things to this really important conversation and discussion around mental health and psychosocial well-being, and it's wonderful this is being taken up. I think we've really seen a movement globally over the past 10 years even, that there's more and more attention to mental health, and I think also maybe a bit less stigma, and more organizations are willing to take it up and to work towards it, which I think is a really important development, but something that we should continue pushing forward. So let's not stop here, but let's really see what everybody can contribute. I also work specifically in humanitarian crises. I spent about 10 years of my life working around the world in settings that were affected by crises such as war, conflict, disasters, including places like South Sudan, Afghanistan, Pakistan, Gaza, Ukraine, Japan. I've been part of many emergency responses, and mental health is always an issue. I have never seen an emergency where there are no mental health implications or problems, and I think that is something to keep in mind as we're now also facing climate change, which will and also a lot of displacement and conflict around the world, which will only worsen these problems. One thing that's important to consider, though, as well, is that stress and struggling with mental health is completely normal. Also, when faced with humanitarian crises, most people experience stress, fear, sadness, nightmares. All of these are completely normal reactions, and we don't want to pathologize them, as you already mentioned. We don't need to label people. We need to actually give people tools to cope, to help them cope, avoid negative coping strategies like alcohol or drugs, and focus on positive coping. We did a mindfulness kind of exercise at the beginning, and we kind of need to help people, give people the tools how to cope with stresses. However, it is also true that about 1 in 5 people in humanitarian settings actually develops a mental health condition, such as depression, anxiety, post-traumatic stress disorder, even psychotic disorder like schizophrenia are increased in these settings. So it is important that we make services available and accessible so that people can easily get the information they need, access services without stigma, without fear. And that is something that we have been working towards at WHO with many partners and many others, including Julian here, Peter at UNHCR, many who are here in the room. So I just want to mention quickly 2 tools that we have at WHO. One is called the Minimum Service Package, and if you were already here earlier, you may have seen a video about it. And that basically gives you an idea of what activities or programs are needed in any humanitarian setting to support mental health. So we don't need to start from scratch. We don't need to think about, what should we do? You can actually go to the MSP. There's also a website, mhpssmsp.org, and see, are these activities and services, are they available? And these include things like coordination with other humanitarian actors, assessing needs in areas are also very important. But then there are things that are also always needed, like, for example, providing mental health care as part of general health services. There are usually not enough specialists. South Sudan, for example, has 1 psychiatrist for 5 million people. So that is not enough. So obviously we will have to strengthen mental health as part of general health care. We have to train community workers, and we also have to work across sectors like social services, education, schools. And the MSP tells you basically what is needed and how to do that. So I encourage all of you to access it and also look at the resources that are linked there that provide a lot of information. And maybe just to mention that the MSP is not only relevant for health. With WHO, I come from a health background, but also actually we've been working with protection actors, those working with gender-based violence, child protection, education, camp management, shelter, nutrition, the list goes on. Mental health and psychosocial support is everybody's job, everybody can contribute, and the MSP describes how. I also want to quickly mention the WHO World Mental Health Report, which just came out this year. There are a few copies up front, so take them so I don't have to carry them back. Even this one is available for anybody. This actually describes really possible, well, it describes the state of the world in mental health, and it describes possible solutions for NGOs, for governments. Service users are also really important, or people with lived experience. Perspectives are in there as well. So this really tries to pull it all together. This is not specific to humanitarian crises. It's really for all countries. So it's a really, really great resource for anybody who wants to do more work in this area. Thank you.
Thank you very much for your comments and your analysis of all these dimensions. And of course, I hope that we will have time to speak about what trauma means in context where life is traumatic all days and all nights. Thank you again. I give word to Shantha Barriga, Director of Disability Rights Division. Please, thank you.
Thanks, Roberto. So as he said, my name is Shantha, and I lead the Disability Rights team at Human Rights Watch. And what we do is we document violations or human rights abuses against the more than 1 billion people with disabilities around the world, and part of that are people with what we call psychosocial disabilities or mental health conditions. So I thought I'd share a little bit of our the people that we've met along the way to help illustrate the stigma that Julian and Inka have been talking about. What does that look like? So we'll go to Indonesia, where we documented the practice of shackling, chaining people with mental health conditions. And where in Indonesia, there are more than 57,000 people who've been shackled sometime in their lifetime, and that is according to the government's own statistics, so you can imagine the real numbers are probably even higher. And my colleague went behind this home and walked toward a shed. And the shed was boarded up. There was no light that came inside. And on the walk up, she could smell the stench of urine. And she peeked through a hole, and she saw a woman crouched in the corner, naked. She spoke to the father, who told her that that woman had been, his daughter, was locked in the shed behind their home for 15 years. This is where she ate, this is where she defecated, this is where she slept, in that same 4 walls. She actually used the stones on the floor to try to break out and created a bigger hole, which they boarded up again. And that left a little gap where they would bring her food through the wall. The family didn't do this because they're the worst intentions. Why? It's because there's a lack of services available, because there is so much stigma around mental health, and the family didn't know what to do. They didn't have a strong awareness of what is mental health and how can we help support someone. So they locked her up in this room. I want to take you to Ghana, where I've done work for more than a decade. Julian has been a part of that work as well. And there we not only documented in many of these countries the impact on people with psychosocial disabilities in their homes, but also in the communities. And in Ghana, there are something called prayer camps or religious spiritual centers, which in many countries where someone is they lost their job, they lost a loved one, they want to go and pray and heal. And so they go to these religious institutions or these religious camps for a few days to just get away, like a retreat. But also what happens in these camps is that people are taken who have psychosocial disabilities. So I went to one of these camps, and I walked up to the so-called prophet. He calls himself a prophet. He runs this camp. And while I'm talking to him about how he says he cured, this person came who's blind, and now they can see, and someone came in a wheelchair, and now they can walk, and he was telling me his stories, and I heard this girl crying. I'm a mom. I have 2 boys. I had just left my youngest son at home, and so of course I was attuned to these tears, and I asked him, who is that? Who's crying? And he said to me, she's a witch. I said, can I go meet her? He was very annoyed by my question, and grumbling, he took me over to this tree. And at the base of this tree was a little girl. She was 5 years old. And next to her was this chain. It was so thick and heavy that was laying on the ground. And he explained that she had been chained to this tree for 3 days. Her stepmother brought her there because she was misbehaving. And they thought she was a witch. And the prophet went on to say there are many, 95% of girls and women are witches. And then I said, oh, really? He said, yeah. And then he summoned this room afar, and then these girls lined up right in front of me. And there's a dozen girls, ages 5 to 15, and he's looking at them and says, she's a witch, she's a witch, she's a witch, she's a witch. I was luckily there with a colleague, and so he took the prophet, and was chatting with him about all of his theories, and I started talking to the girls. And obviously that moment I didn't really know what to say, but I asked them about their experience, and what was so powerful about that moment that I remember, even 10 years ago, was that they talked about how they helped each other, and how they brought water for this little girl who had just arrived. She was the newest one, and how they brought a bucket so that she didn't have to defecate right where she was sitting, and they could take it away. And it was really, there was that peer support, that one of the sort of ways of, that people here work on and promote, that you could see even among these little girls in this camp. But you don't have to go as far as Ghana or Indonesia. I don't know, many of you might have seen the article in the BBC last week about abuses in a mental hospital in the UK, where I was reading it again this morning. It's horrifying what happened. There was an undercover reporter who went in and documented how people were slapped, how people were dragged from their rooms in order to get an injection, and cursed at, and locked in seclusion, isolation rooms for not just 20 minutes, but for days and months, because they weren't cooperative. And these are the real experiences. And for me, I think one of the most challenging parts of our work relates to the stigma, because it's about changing mindsets. We promote changing laws and policies, and we really push for investment in community-based services that are respecting the rights. And by that I mean that the people, as Julian was saying, that the people who are impacted by these decisions are part of that decision-making process, as opposed to medical staff who think they know best about what a person might need. And really, but one of the biggest challenges is really helping change the mindsets in the professional world, in the mental health professional space, as well as families and other members of the community who have influence over the situation. So I will stop there. I have positive and good things to say too, but I feel like I've gone on for a bit, so I'm happy to come back and share some of the hope that we do have, because we do also document some solutions and alternatives to these practices.
Thank you a lot, Shantha. Please, Pamela.
Great, so in case anyone's wondering why I'm sitting on this stage, it's because I do what Atalanti tells me to do. So I just wanted to add a few thoughts as well. Throughout most of my career, I've worked at this intersection of mental health and HIV. And I remember a story. I worked in South Africa for quite a long time, and remember a story from a group of people who were living with HIV. This is now probably 15 years ago, who were attending a support group. They'd started antiretroviral therapy highly, highly stigmatized, but were, after being in treatment for some time and going to a support group, they were riding public transportation home and were talking and laughing about their recent support group session and joking about their medications. And then they caught themselves and they realized that they were saying these things out loud in public transportation. And they laughed about it because they recognized a couple of things. One is that they were feeling well, they were looking well, they were healthy, and for them, for the people themselves who were living with HIV, the stigma and shame associated with the condition was diminished, in part because the disease was not as threatening as it had been. And I think we understand that about stigma, that when we can actually provide good care, particularly for stigmatizing medical conditions, including mental health conditions, that in itself can actually reduce attitudes that are stigmatizing and discriminating. And in this case, they remarked on that, like, wow, we're talking about this out loud. We're talking about, because it's just not as salient anymore. And I think this is a challenge we have with mental health services around the world, is that, you know, in so many places, there's a scary psychiatric hospital that no one wants to be associated with. There are places where human rights are violated. That's not, and when that's the association with a mental health condition, we can understand how that feeds these ideas that are quite damaging and harmful. So quality care, quality effective care is an incredibly important intervention for stigma reduction. The second thing I want to just talk about is, Julian alluded to the fact that I think stigma is a process, and it's a complex process, but one of my favorite conceptualizations of stigma emphasizes the fact that discrimination is the end result, and that happens in the context of power, that you have to have power over the people whom you're discriminating against, and stigma is most often operated and enacted against people over whom the stigmatizer has power. So I think it's important for us to have this conversation about attitudes, but also about discrimination. And what do we do about the discrimination that occurs in the context of stigmatizing attitudes? And what are the ways to intervene that are quite concrete, that give people the tools to both resist discrimination, that enact policies that are protective? All of this, I think, is a very important part of our response to stigma.
Thank you very much, Pamela. Please, any comments is welcome. I just want to add from my part that among other things, we cannot forget, as Pamela was saying, the violence of institution, of healing institution, because this contributes to feed the fear and the stigmatization process. I remember that in Francophone West Africa, mental health hospitals were called the cabanon, a sort of prison for people living there. So this is another chapter of our fight and our effort. Please, who wants to intervene on reciprocally between you?
Well, I would just build on your point, Pamela, about the importance of quality care, and maybe expand that and unpack that a bit. What does that mean? Because I think care or services or support is not about handing over medications. I think, Roberto, you were saying that as well. It's not about, here are your medicines, take them every day, and see me in a month. It's about a holistic approach to mental health. Because so many people in these circumstances all over the world that we've seen, it's because they don't have a job, or they lost their job. It's because they're poor, or it's because they don't have housing. And so what we've been promoting, along with many of our partners, is that we have to look at, governments need to look at, and donors need to look at mental health as holistically, and support various interventions, and which includes housing and employment and social protection programs to address poverty, that all contributing factors as to why people end up in a mental health crisis. So it's really looking at it in a very large lens, as you were saying. It's really not as a narrow lens in terms of a medical approach. And there are some really interesting initiatives that are doing that. But I think the issue is there needs to be more investment in scaling those up, because there are pockets of good practice that we've seen in different countries in the North and in the South. But unless they are really expanded across a country or across a region or across the world, they're really not benefiting as many people as we could, and making sure that the rights of people, of those impacted people with psychosocial disabilities themselves, are at the core. And there's a principle that we stand by in the disability community. It's called nothing about us without us, which is really about making sure that the voices of people, in this case, people with psychosocial disabilities, are at the center of the advocacy, are at the center of the change, are at the center in their own lives of making the decisions, and empowering them and creating space for them to make those decisions is really another important investment that needs to take place in order for us to move ahead. That's what Julian does, so I'm going to hand to him.
Thank you. Okay. Thank you. I think a lot of what you're hearing here has been a real journey of development over what, 20 or so years that I would say global mental health has been working, and that term that Roberto said about social determinants being increasingly recognized, that it's the environment in which we live that defines how well we do and how well we thrive in that environment. I just want to make a little comment about language, because one of the problems we've had in a way in the space of global mental health is that we've increasingly realized that's the case, which takes the conversation out of a world where we were quite familiar with, a world of defining people by having certain types of problems which were kind of linked to certain types of solutions. But then when you start going out, where does the world of mental health end? Are we all supposed to be poverty activists or climate change activists? Because those are the things that matter more than anything else, you know. So we've kind of got to still keep thinking about what we define ourselves as doing. But I want to maybe land a little bit on the membership of Giving Women and the roles that you all have in engaging with people who have emotional needs associated with the situations they find themselves in. And to reflect a little bit on some of the work we've been doing in a few countries in Africa, particularly with people living in very rural communities, often who don't have access to health services. And the first thing we did was to try and find out what language was being used, how their conditions or their behavior or how they were defined within their communities was described. And it was often incredibly pejorative. I mean, you know, words related to kind of madness and associated with being like an animal and being spirit possessed and all of those things. And that was for people who had quite significant problems. But when you start talking about, well, what about if you're distressed, if you're grieving, you know, and it became part of what everyone was experiencing all the time. Well, that invites care and support from the people around you. You give people time to recover when they're grieving, or when they've had a bad time, they've lost a job, or they've been physically sick and they need to recover. So there's these two very different languages, one that set people apart because they were very different, and one that was embracing and bringing them in. And I think what we realize, and some very interesting work in trying to completely change that language that defines epilepsy or whatever it is in places, but we're trying to bring the conversation towards saying, well, those othered people are part of your community as well, and they also need space to heal and space to recover and to be part of everyone's responsibility rather than being shunned as an outside group of people. So I think within the work that you do, many of you, there will be elements related to emotional support for people who've had problems in their life. That happened a lot in COVID-19. And we've really, I think, found that it's most helpful in that space to understand what language is supporting and encouraging of healing and having space to become better, rather than quickly jumping towards some of the languages that tend to say, oh, you're someone different who needs to have someone else sorting you out. No, people remain part of our communities, even if they're in quite significant distress, and we need to find languages that help people to take responsibility for that. And that's a journey that all of you will have in your own organizations, whether it's thinking about people who've experienced violence or people who are very poor and the stresses associated with that. How can we say, well, that's a normal part of living, and we're all part of the solution together to help you in the situation you find yourself in?
Thank you. Thank you.
Should I make a... Yeah, I think that's a really great discussion, and I just want to add one point maybe about mental health systems, since also psychiatric hospitals have come up quite a lot. And just to say, at WHO, we're actually promoting moving away from psychiatric hospitals and really towards community care. We see that most countries in the world actually still spend about 80% on their budget on psychiatric hospitals and institutions. And that is a big problem. And that is also where a lot of the resources go, or people automatically think, oh, mental health, okay, psychiatrist, psychologist, hospital. And we're actually saying, no, we have to think about community level care. So what does that mean? Usually integrating mental health into general health care, into primary health care, training general health care workers so that they can identify people with psychosocial disabilities, mental health conditions, and assess them, provide some initial support or treatment, follow up, monitor, engaging community health workers as well in that process so they can do community outreach and kind of psychoeducation on stress and dealing with mental health challenges. Also, involvement of mental health service users or people with lived experience is also really important. They can often play a role, for example, as part of peer support groups, helping each other, supporting each other, and also sharing their valuable experiences as well, even with healthcare providers and others who are trying to set up services. So I think all these different layers are really, really important, and that's what we want to strengthen. Also secondary healthcare hospitals that have psychiatrists, but that just have people come in and get care there rather than stay overnight, or short-term stays for really severe problems. But what we want to avoid is these long stay institutions where sometimes people stay for decades, for 10 years, for 20 years. People live in psychiatric hospitals all over the world, and that's what we don't want. I want to add one quick example, since we talked about people being chained up, and yes, we see it everywhere in low resource settings. And maybe to just add on a little hopeful note, in South Sudan, in a Somali refugee camp, I was there with a team, and they came across a father who had chained his son in a shed with goats for 7 years. And this son had a psychotic disorder. It's kind of something like schizophrenia. And the family just didn't know what to do with him because he was disorganized, he was running around, he was talking nonsense, he was taking off, and they didn't know where he was going. So their solution was, okay, we just have to keep him here, keep him safe, keep him chained up, and feed him. So like you said, it wasn't, they just didn't know what else to do with him. So the team there actually trained general health care providers in recognizing psychotic disorders, providing medication, providing support, supporting the family, explaining what it is. And within weeks, this son was out of chains. And the father actually held up the chains that in his community, he showed his community the chains that he said, look, I used to chain up my son with these chains, but now he's treated. This illness is treatable. He's part of the family now. He's eating with us again. This is possible. And I think this goes to the point again how actually when we talk about stigma, this is not just us talking about stigma. It's working together with people who are affected, with families, with communities, to talk about mental health and psychosocial disabilities, and have people use their own words and their own experiences to share, because that is what, at the end, what produces stigma is actually people hearing from others in their community and connecting, rather than us just talking to them and saying you shouldn't stigmatize. Over.
Right.
sorry to jump ahead. I just wanted to add another, a positive example as well, just to say what's happened in Indonesia, where we documented shackling, and it's the example I gave of where Eka, the woman, was in the shed. So the government really took notice of the issue, and there's a ban on shackling in Indonesia in 1977, but our work over the last several years showed that the ban wasn't really taking effect. So what the government did in the Ministry of Health is that there's a very good health infrastructure in Indonesia. There are some 10,000 health centers across the country in the community, and they trained 25,000 health workers, with groups that trickled down and trained the trainers, kind of a program, to integrate mental health into primary health care at the local level, so that people were getting help at an earlier stage than having to resort to a stage where they were in a crisis. And it was these kinds of programs really important, because in Eka's case, when you have this father who doesn't know what to do, and the psychiatric hospital might be 2 days walk from their home, how are they feel like they have to resort to locking them up in chains. Also, what Indonesia did is a program called the Knock Knock program, translated into English. Basically, they trained community health workers to go door to door and talk about different health issues. So they talked about HIV, tuberculosis, nutrition, and together with our partners, we were able to convince them to include mental health as one of the health indicators that they should be talking to. So we had people, there were community workers who were midwives and social workers going out to homes, talking about these various health issues, including mental health, helping destigmatize, normalize mental health. And while they were there, they were also seeing, okay, are there people who are here who might be chained, locked up in a room, and then helping to really reach out to them at the very community level. And so it's those kinds of cases where you see the impact is really at the local level, and not necessarily whatever law might be passed 40-some years ago, but really integrating it into the day-to-day practice of people who are out in the communities who can actually go and make sure that people are getting the support that they need.
Great. So I want to follow up on 2 threads and then maybe make a third quick point. One thread was around the prayer camps. I was talking to some of you about work in prayer camps, and the Human Rights Watch's work has inspired a number of folks to try to intervene in prayer camps. And my colleagues and I are part of that the follow-up of that inspiration, where we're working with colleagues at the University of Ghana, Professor Angela Aforiata, to build on her work, where this is a professor who's been introducing collaboration between psychiatric nurses and prayer camp leadership, so that some of the more abusive practices can be eliminated by providing care. Our team on the UW side, which is led by Dror Ben-Zev, visited Ghana just before the pandemic started, and visited several camps and talked to people about what kind of skills would you like to have if you could do something besides chain, seclude, force fasting? What might that look like? And we introduced a set of practices. For example, how can you talk someone down? How can you help calm someone? How can you help them relax? And one of the interesting things about prayer camp staff, some of them have been treated at prayer camps, right? Often they are people themselves who have been admitted to a prayer camp because of a mental health condition. And we found that those particular providers are very sensitive to wanting to have skills to know how to better manage people who come in with psychosis and other kinds of agitation. So we're now working to test an app that we co-designed with them that gives them, in their smartphones, and they do have smartphones, gives them tips on how do you use some low-intensity psychological interventions to help reduce agitation, to really help address some of the common behavioral problems that they see when people come in acutely ill. So promising work that we're just beginning to scale up to the next phase of testing. But the other thing I wanted to say, I look at the title of this conference, which is Mental Health, Not Just a First World Problem, How Can We Act? And I also want to say in this conversation that these kinds of human rights challenges are not just other world problems, that these in fact are first world problems as well. And I think about the United States, where the prison system is the largest mental health care provider in our country. And I remember in my former job, I was a funder, and I'll say something about that, and I was a funder of global mental health research. And my boss used to say, can you imagine if you received a cancer diagnosis and you were sent to prison for treatment? Or you had diabetes and you were sent to prison? Like, no one would tolerate that. But we do tolerate that for people with mental health problems. We don't actually say anything about it, and yet that's the de facto situation in the United States. The positive side is that increasingly prisons are recognizing this, that they are mental health care providers, and some of them are beginning to introduce real care in the context of imprisonment. But there's an entire story about why people are in prison to begin with that we can go into, but that's another thing. Anyway, and then my last comment is this question about the struggle that our field has had about what are our boundaries, right? Yes, social determinants are incredible contributors to the development of mental health conditions. And as all of us have said today, wow, if we could realize the Sustainable Development Goals, we would really improve the mental health of this planet, right? I mean, that would be amazing. But all of us are advocates in the roles that we play. And there's always that decision about, well, what do I emphasize depending on who my audience is, right? Okay, I'm trying to convince you that it's really important to invest in mental health. How specific do I need to be? How focused do I need to say the problem is? And I would love to just have a conversation with this group to hear how we're all facing this. And this is actually something that Jeremy Schiffman, who thinks about priority setting in global health, says this is one of the challenges for the mental health field, is that what would enable us to be a priority in global health typically requires being pretty focused about what the interventions are, how effective they are, and how people can scale them up readily. And if we say that the intervention is everything, that becomes more difficult to convince. On the other hand, there's got to be a way of making the point that these require intersectoral action, right? That when you do that intervention, you help us, and we can help you too accomplish what you need to accomplish. So I'd love to hear from the wisdom in thinking of this group, because I think we've all struggled with this.
I'm happy to have a start at that huge question. I think what we need to do is we need to recruit people. We need to recruit people to be thinking about mental health in their space. When global mental health started, we had exactly that same thought, is what are we going to focus on as the big thing? And it was largely about scaling up access to care, which has come out a lot here, because it is the basis of a lot of other recovery as well, social recovery as well. But I think it's very apparent that there's a tiny number of people who just do mental health, as should be the case really, because people's other health problems or other social problems are often the spaces where they are distressed and can best seek solutions for that. So Pamela and I were talking earlier about the many years of work of looking at mental health within the HIV sector. And we've had a much shorter history of looking at mental health within the sector of people who have neglected tropical diseases like leprosy and lymphatic filariasis and these other often very, very excluding, stigmatized conditions. And it's been a fascinating process, and one that we've done in a much shorter space of time than in HIV. But I do think that we've got some common lessons now about how we convey the importance of looking at mental health and well-being and distress in completely different sectors, which thank you very much for inviting us to speak here, because that's exactly this space, isn't it? It's having people who work in, I don't know, other health areas or education, thinking and having the tools at their fingertips to do something about the mental health conditions of the people in front of their community, not by sending people into a mental health space, but normalizing emotional consequences of their work being addressed in their own space. And I think that's a revolutionary idea, is to give everyone a sense of responsibility and confidence in engaging in mental health as an issue in the space in which they're working.
Thank you very much. Just a very short comment, because your very motivational words mentioned a lot of problems. And as a psychiatrist, what I would like to emphasize is which quality of skills of healing process we will be able to activate. Because in many cases, we know that in front of the scarcity of mental health professionals in different countries, before you remember the low number in many countries, the solution was the training of many mental health workers. But in my experience, I saw that most of them just prescribe medication, don't hear women, youth, men. So we continue to reproduce a poor healing process. I think that we are in need to reinvent and even to include other skills, other actors, as you were saying, in order to solve this problem. Because if the lack of professionals is a big problem, the solution is not a poor training for a poor quality of healing, just drug prescription. Thank you.
Maybe I'll jump in there, because I think there's a great example, Roberto, in Brussels that we've documented in Belgium. So there's an initiative, a program called Tandem Plus, and what they do, rather than they're against forced hospitalization, they're against forced treatment of people with a mental health condition. Instead, they train their staff, who are community outreach workers, social workers, not medical professionals, to meet people where they are. So if you're in a crisis or you need support, you call them, or you have a friend call them, if you're not in a position to give them a call, and they come to your home. And they ride the bicycle or they take the trams. It's very inexpensive. They come to your home, and then they help you help understand where you are. And it might be because you have a stack of bills and it's making you very anxious, and you haven't paid your bills in time, or that your apartment is a mess, and that you haven't cleaned your apartment, and it's making you very agitated, or something's happened in your life. And so they look at your whole life picture, and they help think about, okay, well, let's help you find a job. Let's help you deal with this, pay off your bills. Let's help you find someone who can help you clean once a week. And by building these elements of your life back up, and offering as well psychiatric support or counseling or therapeutic support in a way that the person actually desires, they've had really good success. In doing it in a way that's not a medical approach, but much rather a community-based approach that so many of us are talking about. And it's one of those initiatives that could be scaled up, because it's not intense financial resources, nor it's not linked to any particular hospital or any particular initiative. It is really about trying to make sure that people are getting the help to deal with the triggers in their own lives. And taking that holistic approach, or that way of training people in a different mindset, Roberto, as you're saying. And I think there's also an initiative of the World Health Organization called Quality Rights, right? Maybe you will speak to that, Inka, which I think is also helping to change the mindsets. away from coercion, away from psychiatric hospitalization, to help people understand some of these techniques for de-escalation that don't require restraints, that don't require chemical restraints, what we say, injecting someone against their will or forcing pills down their throat, like an animal, which is frankly what happens in so many of the countries. And you know, it's a huge undertaking, but it's exciting to be a part of this conversation and for people here to be interested in these issues, because it feels like there's momentum and it feels like there's a genuine interest, especially when mental health professionals like yourself, Roberto, say like we need to change things. You know, we need that leadership from within that profession to help, because people like me, who are human rights folks, aren't the ones they'll listen to. It's people like you, Roberto, who they will listen to as a peer to say, look, we need to change the way we're doing things because this is not a way to treat someone with dignity.
Shantha, yes, please. And after, if there is some question from the audience, is where now. Thank you.
Yes,
Please,
just a very quick point. And yes, I think what we definitely need is like a whole person approach. We cannot see somebody just like, oh, this person has depression, so let's deal with depression symptoms. No, we have to think about the whole person. Like I remember somebody with bipolar disorder who came to care, and then it was the discussion, well, what did they need? And then we heard that they were being threatened to be evicted from their apartment. So it doesn't help to just give them medication if they have this huge issue looming over their heads. So we definitely need to involve actually many different actors and sectors. And in the humanitarian setting, actually, we have different coordination groups. Usually they take on things like water and sanitation, nutrition, shelter, camp management, health, protection, GBV. And there, the MSP also explains like how these different sectors actually can work together and how they all have a role to play in mental health by first of all recognizing how does the sector relate to mental health. Say water and sanitation. Actually has a huge relationship with mental health. If we think about menstrual hygiene, for example, very relevant for women and girls and their ability to go to school and their well-being. Latrines, how are they set up? Are they private? Can they be locked? Are they safe? Are they lit at night? These are huge factors, and this is where we're actually, with the mental health and psychosocial support, I was at a recent webinar with WASH actors discussing exactly that, like how can we promote that, or shelter. Helping people choose their own shelter and advising on how it should look like, making places where you have displaced person camps, setting them up in a way that communities and families stay together, how you arrange things, making communal spaces, making green spaces, including youth centers, how you set up a camp, has a huge impact on mental health. So I think we need to continue talking to non-mental health people and really expand to people working in completely different areas and discussing, well, how can we help each other, and how do our areas relate, and how can we advocate together for better mental health of the people we're trying to support over.
So I'm just going to interject here. Sorry, the app the questions were not loading on my phone. So I apologize to all of those who have sent in amazing questions for us to ponder. We're coming to the end of this panel, sadly, because it's been absolutely inspirational and just amazing. I'd like to just pull one question that will maybe help us to just round out this discussion that was posed by Maria. What's the greatest barrier for the development of a sound framework for mental health care in your experience? Lack of funding, policy, education? Maybe you guys can just wind in your closing remarks with consideration of this question. Thank you so much. Go ahead. Yeah, you can go ahead. Oh, repeat the question? Sure. So, what is the greatest barrier for the development of sound frameworks for mental health care in your experience? They're asking the question, they're making some proposals of, is it lack of funding, is it policy, education, could be something else. Up to you to just entertain. Thank you.
I'll start, and then because I'm also going to say something that Inka probably should be saying, is that, first of all, there's been a tremendous increase in the number of countries that actually have mental health policies, right, over the last 20 years, and that's been thanks to the work of WHO and really stimulating and helping countries to develop policies and plans and to implement them. Because you can have a policy that's never implemented, and that's the case in many places. And I would say that some of the barriers around implementing those policies do have to do with financing and being able to actually, I've worked in places that have a really ambitious plan for community mental health. I can actually name a lot of countries like that, but that's not fully implemented. And often it's because of political will sometimes it's because of funding. I think one of our huge challenges now, for 8 years I was at the National Institute of Mental Health. We're the largest mental health research funder in the world, and was building this evidence base around what can we do in countries that lack mental health specialists, right? How do we build the evidence base that task shifting is a good thing and an effective thing? There are lots of studies. We've got this incredible evidence base now, but there are very few people that support the sustained implementation of those kinds of innovations such that they can happen countrywide and that many people can get access to them. There are lots of tools, but I think being able to support them sustainably is still a challenge.
Yes, exactly. And maybe to just add to that, I would say, yes, we definitely have the framework. There's also a nice framework in here, if anybody wants to pick it up, which talks about all the necessary elements for mental health in a country, which is really multifaceted and needs many different components. I think we have the tools, we have the frameworks, we have the materials, but what is often needed, I think, is the political will and the resources that are there, need to be there to kind of push things forward. I would say definitely more, not just more finances, but reallocation of resources. So resources, for example, that are now going in one direction or that go only to psychiatric hospitals or even donors that are funding humanitarian emergencies. We need to make better informed decisions of where we need to build up systems. And I think that, again, needs advocacy and helping decision makers access information about how to make decisions about this resource allocation. And then, of course, political will and commitment is really important, and this cuts across everyone, not just government, even at the personal level. Like, what can each and every one do in their own way to support mental health, to not stigmatize people with mental health conditions, for inclusion of everybody, regardless of their abilities, their conditions, their stressors, their history, their migration background. Anyone is really social inclusion, I think, is huge, and this is the task of each and every one of us. And then, of course, working with different actors across sectors to strengthen human resources in mental health. A huge gap globally in skilled mental health workers. And there's also actually some reason for that is also stigma. Again, people say, oh, I don't want to go into mental health psychiatry. These people deal with crazy people. No, we need to overcome this. We need young people to be interested in mental health, to pursue education in mental health. We need the institutions to support that. So I think if we have the human resource base, it will also greatly help mental health care as well, and scaling that up.
Just to build up really on what you were saying, which is actually kind of where I started as well, it's about the way we interact with everyone around us, isn't it? And at a political level, individual decisions can have an enormous impact in, for example, resourcing things, but it's actually in our day-to-day encounter with our neighbours and our family members and the people who we meet at work that makes a transformational difference in how those people experience their condition. They might still have the same condition, but if they're accepted and supported, it's a very different experience from if they're not. I actually feel incredibly positive about this, because I think we've seen such a revolution in the last 10 years at least, and then COVID-19 had an enormous impact on that shift from othering to starting to have a conversation about all of us are having a similar kind of experience. And there are some people who as a consequence, have more problems than others, but that we can all be part of building communities that help resilience. So it does go from every level. I think historically, it's been that unwillingness of leaders to be associated with anything related to mental health because of an implication they might have a personal or a family kind of reason to support. And that's starting to break down now. And I really think that we're moving into a different era where that opportunity to close the enormous gap between need and resources in our space is really coming forward by people thinking, what can I do about mental health in my own world? And that's what will make the transformative difference, I think.
Yeah, I think there are two barriers, I would say. I mentioned them already, but I'll reiterate. One is mindsets, which you were just talking about, Julian. And in the research we've done over the last 15 years, it's really been the one phrase that I've heard again and again when meeting people with psychosocial disabilities is they say, I feel less than human. And how can we get away from that sense of their own self-worth, but also how people treat and interact with them. And it goes to sort of how we all engage in breaking some of that stigma. And the second barrier, again, I agree with Inka, it's not about the framework and not about the policies. We have all these frameworks. I think it's about making sure not that only that there's funding, but that the funding goes to the right kind of initiatives that are community-based, that are rights-based. And so, Pamela, we're going to have a follow-up conversation because I'm very concrete. So one outcome of this conference, I hope, is that Angela Foriata's husband happens to be the Minister of Finance of Ghana. So we can start brainstorming about how we can influence, make sure that the funding and that there is adequate financing for mental health in Ghana, but also that it goes to the right kinds of things. And that we can start shifting some of the change that we all are pushing toward in the different countries where we work. So.
Thank you so much, Roberto, for taking the time, in spite of COVID, to be with us. Thank you, amazing panel. I think, again, it was such a rich conversation, but I think that ending with what Julian, you said, each and every one of us can change that kind of attitude with the people around us. And I think often fear has been one of the issues where we don't know how to interact with people who are going through some mental instability and so on. But I loved what Inka said. It's normal to have the reactions you have. If you are living in poverty, if you have decisions around health, it's normal to have those reactions. We mustn't make ourselves or make the people around us think that there's something wrong with us. And I think that, you said humanization, but I think also normalization of those ways that we are is really, really part of our responsibility in our daily life. So thank you so much. This was amazing. I mean, oh my God. So really, really great.